Hi, this is Brian Kim. I'm going to share with you case number 253 in the Best Way to Do Cataract Surgery series. And the title of this series is not to suggest this is the best way, but to get you to think critically of your technique, finding ways to refine and hone your technique so that you can provide the very best for your patient. So this is a patient who has quite a bit of a hazy cornea. On top of that, a small pupil. On top of that, about a 2+ dense lens. So not the most ideal case. This patient has quite a bit of issues, not just a cataract. And you're going to see how I'm able to navigate throughout this challenging situation to complete the cataract surgery. So you can see this is the cornea, quite a bit hazy, also somewhat of a small pupil. And like I said, it's about a 2+ dense lens. And this eye, for whatever reason, is kind of stuck down. I did perform a block, but it's not straight, but it's kind of like stuck down. I'm using the cotton tip to hold the eye in place and straighten it so I can make my corneal mark, which will help me to center and size the rhexis. But then as I try to turn the eye, I'm not able to control it very well. So I'm using forceps to hold the eye, and that's the incision for the hydrus. I'm not really going to show the hydrus in this video because the video is really not going to focus on the hydrus part. So go ahead and inject some intracameral epinephrine and then some dispersive viscoelastic. I'm using the Orlock technique to turn the eye. And as you can see, I'm having a hard time turning the eye. And so now that I have gripped it with forceps, I'm able to turn the eye up, and then I make my paracentesis on the right side. So again, it's really an interesting eye because it's turned down and not up. Again, the Bell's reflex usually causes the eye to turn up, which is really different for this patient. So this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. And these are the sharp tip Moria microrhexis forceps. I puncture the center, and then grabbing the right side of the tear, going around circumferentially. You can see this rhexis is going to be about the size of the pupil. This is a medium-ish size pupil. I'm pushing some more viscoelastic, and then I go ahead and continue the rhexis. Want to make sure I have good visibility. Going around circumferentially. Excellent control with these forceps. But again, the hard part is this is just a hazy cornea. Okay, finishing off the rhexis, burp some viscoelastic out. And this is the Capsulorhexis hydrodissection technique. I place the cannula under the rhexis edge contra-incisionally, point the tip down. I'm kind of jiggle the cannula in the Capsulorhexis, lifting the lens up, decompressing the bag, getting under the rhexis edge around the left side, sweeping under the rhexis edge on the left side, and then hooking it on the right side, and the lens spins. So I know that the lens is free. Lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. Start to remove the epinucleus material, sliding the chopper under the rhexis edge contra-incisionally, the phaco tip vertically sub-incisionally, fracturing the lens in half, and that is the double chop. And immediately I start to notice that I have quite a bit of chamber collapse. So go ahead and proceed with the cross chop, placing the chopper under the right heminucleus, hooking the peripheral lens, and crushing the lens against the phaco tip, and that is a cross chop, bisecting the right heminucleus in half. Before I go after that first quadrant, I come out with the chopper and I hydrate the incision. And I'm not sure if it's a short incision or accidentally widened the incision because this eye just wasn't cooperative. I decide to place a suture through that paracentesis incision. I try to make it rather tight. And I could have gone and made a new paracentesis incision, but I decided to just go ahead and do the case through that same para. But again, it's going to be tighter, hopefully, because of that suture. And so anytime you have poor chamber control, you have a lot of fluid coming out of your incision, whether it's a not well constructed incision or a short incision, you can either place a suture in that incision or you can abandon that incision entirely and create a new paracentesis incision. So I place the chopper under that first quadrant, crushing that first quadrant, lifting it up within the pupillary plane, crushing it in half into small pieces, and then emulsifying the lens piece. So again, in this case, I used the chopper to lift it into view because this pupil is small, and then I crushed it with the instruments and then emulsified it. Lifting that second quadrant up with the chopper in the same manner. Once I am able to prolapse it up so it's visible within the pupil, I'm able to use mechanical fracturing forces to cut the lens into smaller pieces and then emulsify it. Turning the second heminucleus in front of me, placing the chopper around the lens, hooking it, and then fracturing it in another cross-chop maneuver, separating the lens pieces, performing another cross-chop maneuver around the third quadrant. You can see how tiny this pupil has become. And again, somewhat of a dense lens. As you can see here, I'm just really trying to make sure I'm getting under the rhexis edge as I grab that third quadrant up with some vacuum, crushing it between the instruments, and then emulsifying the lens piece. Very important not to use vacuum when you're not in the middle. You have to make sure you only use a vacuum when you're in the central safe zone in the middle of this small pupil. Cutting the lens into smaller pieces, I'm using mechanical fracturing forces, and then gingerly emulsifying the lens piece, again within the pupil. So again, a small pupil, somewhat of a dense lens, and a cloudy cornea. But because of the mechanical fracturing principles and concepts, I have very good control of my instruments. I know where they are within the capsular bag. I'm able to fracture the lens using cross-chop maneuvers, hooking the peripheral lens, hooking it and getting around it with the chopper, crushing the lens with the instruments using mechanical forces, opposing forces to crush the lens. And then I'm able to hook the lens pieces up into the pupillary center, making sure I can visualize the pieces, and then crushing it into smaller pieces, and then emulsifying the lens pieces. So even though I have not a great view, I'm able to still proceed with the cataract surgery, feeling confident and safe as I disassemble the lens. So I grab that third quadrant up. Again, it's rather loose, but I'm trying to be very careful. Went ahead and grabbed it with some vacuum, pulling it up so I can see it, crushing it between the instruments, and then emulsifying it. So now this is the last quadrant. I'm turning it gently with the chopper, using some vacuum to lift it up, getting around the lens with the chopper, flanking the lens on either side, crushing it in half. Using some vacuum to grab that fragment, crushing it between the instruments, and then emulsifying it. And these are one of the last pieces here. Again, being very careful, I'm not using vacuum. You see that? When I manipulate the lens with the phaco tip, I'm not using any vacuum at all. I'm using the phaco tip as a manipulator to manipulate the lens piece. But once I'm ready to grab it to emulsify, I activate the vacuum. So you can see on the right side of the screen all of my fluid and when I'm actually engaging fluid and when I'm not with the phaco tip. And so that's a very important concept and principle, which again hasn't really been talked about or taught. So remember, you don't have to engage vacuum all the time. Don't make the phaco tip a one-hit wonder. You don't want it to just do what it's supposed to do, which is just emulsify. You can use it as a lens manipulator, as I have shown throughout this case. So now that last quadrant has been removed, and now it's all about removing the epinucleus. Very carefully, you want to make sure that, but before I get to that epinucleus, there's one more nugget there. I used a chopper to loosen it up, and then I grabbed it with some vacuum and emulsified it. As you can see, I never grabbed the iris throughout the case. I never accidentally grabbed the iris and causing any damage. I didn't feel at all worried that I might hit the posterior capsule. And so I just very carefully grab the epinucleus with the phaco tip, and it comes right out. So I take the chopper out, push BSS in, Oh, before I do that, there's a little nugget there. So I stop, put the chopper back in, protect the posterior capsule, and with the posterior capsule down, I gently buzz that piece of endonucleus. So that little fragment's gone now. Take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. Start subincisionally removing the cortical material from anterior to posterior. Again, a terrible view. This patient has a cloudy cornea, small pupil, somewhat of a dense lens. Fortunately, the lens, I was able to spin it, which made my life a little bit easier. But again, I leveraged mechanical fracturing, hooking the lens up with the chopper, being very mindful about when should activate vacuum. You don't want to accidentally eat the iris, and you certainly don't want to eat the posterior capsule. Using the phaco tip as a lens manipulator for a lot of that was really helpful, because now I have two manipulators, not just the chopper, but the phaco tip as well, so I can manipulate the lens pieces. And by doing it this way, I don't have to worry about accidentally grabbing the pupil, the iris, or the posterior capsule. Turning infusion off and then pushing cohesive viscoelastic to fill the bag. Being very careful in ginger when I take the INA handpiece out, turning off the fluid. I'm going in with the Lester, just trying to check that the rhexis is intact, because it's really hard to tell with this case. And fortunately, the rhexis is intact. Switching to the viscoelastic cannula, pushing some more viscoelastic in, turning the eye away from me so I can see the rhexis edge, which allows me to place the single piece acrylic lens into the capsular bag. I push some more viscoelastic in, and as I push it in, I can see the rhexis edge, and I make sure the leading edge of the optic goes underneath the rhexis, and I place the lens into the bag. So you can leverage that visibility of turning and rotating the eye so you can see under the rhexis edge in these small pupil situations. Turn on irrigation. I want to make sure that the lens goes into the bag completely. And so that's why I'm using the Lester here to check, because you never want to assume. As I tilt the optic up, I can control it with two hands using the IA as well as the Lester. And I'll make sure that both haptics are in the bag. I'm tilting the lens up, removing all the viscoelastic from within the bag and underneath the lens, using the Lester to retract the pupil, making sure that both haptics are within the bag, which I did. Switching to visco mode, removing all the viscoelastic from within the anterior chamber, and then I'll hydrate my incision. So again, this is a patient who has diffuse corneal scarring, somewhat of a dense lens, a 2+ dense lens, as well as a small pupil. You saw I leveraged mechanical fracturing, double chop, cross chop, and then using the chopper to hook lens pieces up. And not only that, I was able to use the phaco tip as a lens manipulator as well. Very important not to activate vacuum when you're using the phaco tip as a lens manipulator, because I was manipulating the lens close to the pupil edge. I was manipulating the lens within the capsular bag, and that is not the time to turn on vacuum. And so I used the phaco tip like a chopper. I had two lens manipulators, and as a result, I was able to, in a very controlled way, position the lens pieces in front of me, presenting the lens properly, crushing the lens with mechanical forces, and then disassembling this lens in a case with a cloudy cornea and a small pupil in a somewhat of a dense lens. So I hope this was helpful to you, and I thank you for your attention.